Hey, everybody. Thanks for tuning in again to Palm Peeps. We're very excited today. We have a special late breaking episode today. We put this together in the last few days, and we have two great experts to really talk about the changes that are occurring right now surrounding NIH funding and policy. We think this is really important for medical research going forward, for trainees or young career investigators who have grants. And it's still a little bit opaque and there's a lot of uncertainty, and we wanted to try to help answer some of that. So we're bringing this to you in real time. This episode is coming out on short notice. And if you have questions or other things that come up afterwards, please reach out to us on any of our platforms. Christina, how you doing? I'm excited that we'll be able to provide this information to everyone.
Hey, Firth. Yeah, as always, great to see you and very much looking forward to this. I know on Plum Peeps, we do a lot of different episodes, and we also want to cover great pulmonary and critical care content, highlight our fellows, and really talk about, I think, an issue today that's so relevant to everyone listening today. So, really excited to be joined by two amazing guests, as you mentioned. And I'll go ahead and introduce our first guest who has been on Plum Peeps before. So, glad that he's returning, but excited to introduce Dr. Jack Awashna. Jack is a Bloomberg Distinguished Professor at Johns Hopkins School of Medicine and Johns Hopkins Bloomberg School of Public Health. I get to work with Jack on a daily basis, and his office is right down the hall from mine, which I love, and just getting to hear thoughts and share my thoughts with him. But outside of that, Jack is a critical care physician. He has a broad focus on research, but really understanding the broader context of critical illness and the long impact on patients' lives, focusing on patients that have been hospitalized with pneumonia. Super productive, successful researcher, fantastic mentor for our fellows, numerous publications, and so excited to have you on here, Jack. Thanks for coming back on Plum Peeps.
Always happy to come back.
Yeah, thanks, Jack. And I should mention, this is your brainchild a little bit. You reached out to us about this important topic and we latched onto it. So thank you for doing that. Equally excited to welcome Catherine Hibbert to the show. Catherine is a pulmonary and critical care doctor at Massachusetts General Hospital. She's an assistant professor of medicine at Harvard Medical School. She's also the MICU director at Massachusetts General and the vice chair for critical care. She has an intimate understanding of hospital finances and how these things impact people within the hospital and their career development. And so we're really excited to get her viewpoints today. Catherine, welcome to the show.
Thanks so much for having me. I'm really excited for this conversation.
Yeah, absolutely. Before we go forward, just our standard disclaimer, we're not really going to be talking about patients today, but if anything does come up, everything will be HIPAA compliant and protected. And most importantly, the viewpoints expressed today are our own, and they do not necessarily reflect the opinions or positions of our respective employers. And so with that, let's dive in. So Jack, I just want to start with you. Some people may have grants and really understand how all this stuff works, but other people may only have heard about it a little bit or have a murky understanding. So in a big, broad sense, how does grant funding work for researchers who get them from the NIH? And what's the difference between direct costs and indirect costs?
Thanks, Turf. Most people shouldn't understand this because it has worked so well since the 1940s when it was invented as the basis of the public-private partnership that has made American medicine so great. So there's no reason until Friday night for trainees to have devoted any time to this. It's much more important that they be thinking about how to manage vents and how to manage sarcoid in the outpatient setting. But then all of a sudden, a new existential threat happened. And so let me talk a little bit about the way for decades American science has been funded. It's been funded into things that are called direct costs, which are the things that are used up by any specific grant. My time, reagents, surveys, and then indirect costs, which go to do the shared infrastructure that's used across grants. And while this may seem very odd, it's actually an incredibly common funding mechanism, right? So in Medicare, my time is paid for as a professional fee, and the cost of the nurses and the beds and the other part that are essential to providing patient care go in through what's called a facilities fee. And that sort of idea that you would divide up some parts of it to the very specific provider and some parts to the group that needs to provide the infrastructure that makes that care or that science possible is quite common. As you might imagine, it's impossible to do most of my research without shared infrastructure. No roof, no lights, no Wi-Fi, no computer, no centrifuges, no big data, no science. And it also, you can imagine, it's much more cost efficient to provide those in a shared way than to force us to use them all up and burn them at the end of each grant, as opposed to sharing them and getting the economies of scale across grants. So the indirect costs are the part that are paid directly to the university to cover all the shared costs, the research equivalents of the beds, the nurses, all the other folks who make our hospitals great for our science.
Thanks so much for explaining that, Jack. And I think, yeah, right. As you said, a lot of people may not have heard about this before and really don't understand quite the impact that the cutting down, at least for some state, 15% of indirect costs through the NIH, which, as you mentioned, just was released about a week ago now. But I think that the four of us on here today, those listening today, are really impacted and going to be impacted across institutions, across different domains. I think the four of us today, in our heart of hearts, the foundation and mission and purpose really focuses on trainees. Catherine, and I'm wondering in your different roles with your vice chair critical care research, your Mickey director hat on, how do the cost of research interact with running the education missions of institutions as well as the clinical missions?
Yeah, it's such a good question. And I think healthcare finance is one of those things that I did not understand at all through all of my training and my early years on faculty. And I'm not sure why we don't learn more about it. But when you think about the operational budget of an academic medical center, wherever that medical center is, that operational budget has to cover a number of things. It covers running all of the facilities, as Jack mentioned, right? Keeping the lights on, making sure the spaces get cleaned, that they're heated, that there's paper in the printers, all of those things. It also, that operational budget also subsidizes clinical care, right? It subsidizes clinical care that's provided to people who are not generating a lot of revenue for the hospital, whether it's medicine patients on Medicaid or Medicare, whether it's community health missions, whether it's other sort of mission-based projects that the hospital is running. And then, of course, the operational budget helps subsidize and cover educational costs. So when you look at that budget, we do get paid to pay our trainees some money, but most hospitals are subsidizing how much they're spending on trainee education, salaries, benefits, all of those things. And so when you talk about a significant hit to an operational budget, like a significant cut in indirect costs, and just for reference, the state of Texas got over $500 million of indirect costs in 2024. We're not talking a small amount of money. We're talking large amounts of money, obviously divided over multiple medical centers. But when we talk about cutting down that pool of money that's available to cover keeping the hospital safe, warm, lit, running, and all the research spaces the same, subsidizing clinical care that we believe is essential to our mission, and covering some of the educational costs of our trainee, whenever you shrink that pot, difficult choices are going to have to be made, right? Do we sacrifice clinical programs that don't generate revenue, like pediatrics, which has been cut from multiple medical centers, at least in Boston and in the past couple of decades? Do we sacrifice our mission for community health and outreach to those populations? Or do we shrink our training programs? Do we start to think about training fewer residents and fellows because we can't afford to train all of them? Do we shrink our research mission? And all of these things, unfortunately, interact together, because once you start to shrink a research mission, for example, if we're not getting indirect costs reimbursed and we have to pay for them, we won't be able to fund as much research. We're going to have to cut research programs. That's going to affect trainees because it's going to reduce the sort of reputation and profile of our institutions. It's going to affect training opportunities with mentors. We're going to lose crucial people from the mentorship pipeline for our trainees. And then actual training opportunities might also start to be affected. So it's hard to encapsulate in a short discussion, but the impact would be massive. And I can see impacts on all three parts of the mission.
Thanks so much, Catherine, for going through that. Yeah, it is baffling sometimes about like how much of a mystery this is to us as we get through our training. And of course, we're focusing on our patients and patient care. And so we should be learning those things. And as Jack said, it's best to not have to pay attention to it, but it's such a huge black box for a lot of us. And there are a million great books on all these topics, but I'll just shout out a couple. If you're really interested in how these are tied in to medical education, A Time to Heal by Kenneth Ludmeyer goes really through that development. The Transformation of American Health Insurance by Troy and Brennan really looks at how this development. So there are a lot of great books out there if you want to become more well-versed in this.
And I'll just say one other thing, which is that this threat to indirect funding is coming while there's also a lot of threats to our mission on other fronts, whether it's Medicare and Medicaid cuts or affecting which programs we're allowed to offer to our patients. And so I think one of the things that's so hard is it's not that we're focused on this conversation on the cut to indirects, But there's other financial headwinds that all of us will be facing in the years ahead, dropping reimbursements from private insurance. All of those things together, I think, could really um, be a financial maelstrom that will be very hard to survive for some institutions.
That's why I think it's so important, Catherine, that we not pretend that this is a good faith conversation about how exactly should we balance what the line is, and should my staples go on the direct cost where my stapler goes on the indirect cost, right? This is in the context of 3 weeks of sustained attacks on the NIH's ability to support academic freedom, to support recruitment of the very best trainees, and just radical holds on funding. It's literally an unprecedented attack. And so it's really important that people not think of this as just an accounting issue. This was dropped at 6 o'clock on a Friday night. I don't know a lot about politics, but I think you don't drop something at 6 o'clock on a Friday night that you think is a good idea and that you're really hoping is going to dominate the coverage. You do that the Friday night before the Super Bowl, if you're hoping people are going to be too distracted to realize how bad of an idea this is, because this is a bad idea that just has widespread ramifications.
Yeah, thank you for framing it in the broader context. And then to be specific, because we've referenced this multiple times, last Friday, there was an announcement about cuts to indirect costs through NIH grants. Jack, can you just tell us very specifically what they said? Does it apply to all grants? Is it active grants? Is it future grants? Just so our listeners have a good understanding of what the change actually was.
So it's a little hard to know because things are moving so fast. It was released on Friday night at 6 p.m. with a tweet at the same time that attacked individual institutions, which is nearly unprecedented in the history of NIH communications. I would encourage people to go back and find another notice of award that actually calls out the indirect rates for individual institutions in a policy document like this. I've certainly never seen something like that before. And so exactly what it means is hard to know because there are lawsuits filed before the end of the day on Monday. But what it asserted was that instead of the indirect cost rates, which were worked out between universities and institutions and typically ran between 50 and 60% for large institutions, those would only be covered at 15%. So what does that mean? That means every few years, universities have to open their books and they show all the costs that they're spending on research. And the Department of Health and Human Services, where we just have a new secretary, goes through and says, under the congressionally mandated rules, these are the costs that you're allowed for us to pay for. And they figure out what that is. And then for convenience, they figure out that is a percentage of the total direct costs. And it's just an easy way to make sure things fluctuate back and forth. But what's really important is these are based on, of all the costs the university has already spent on research, what smaller fraction of those will be reimbursed. This is not overhead. This is not profit. This is of valid proven expenses are going to get caught. That's the way it's always been done. It's been done for years. Everybody argues about exactly whether their costs should be a little higher, a little lower. But most premier institutions, again, run 50 to 60% because it's expensive to run really big buildings in the center of downtown Boston or in the center even of Baltimore or in Columbus, Ohio, or in Houston, Texas. They just said, we're not doing that anymore. We're only paying 15%. And of course, 50% wasn't covering the costs. Cutting that to 15% for everybody, uncorrelated with their costs, is just saying that contract we signed with you, it's no longer valid. And indeed, they said it's no longer valid effective Monday at 9 a.m., which is not the way I understood contracts to work. I thought they were negotiated things that you could count on this. And part of the whole point of science, lots of big intellectual risks, very little unpredictability in the administrative space. So we can focus on the big intellectual risks. Since then, it's been a tumult, and by the time this podcast comes out, it'll already be out of date. There are some lawsuits that filed and won a temporary restraining order. It's incredibly important to note that's a temporary restraining order. That does not mean that this has been backed down. There's been massive turnover of senior NIH officials who've been there for years, suddenly resigning in the middle of the night. There's been a memo that suggested that actually this thing that was done was illegal because there is I'm not a lawyer, and so this is definitely not lawyering, but that it's actually pretty clearly in violation of the Code of Federal Regulations. And so they had to walk it back, but it's not a permanent walk back. All of this is just a mess. But what it seems to be is there was at least a period where there was a hold on new funds being issued. That would be at the lower period. And right now, federal policy remains that after this gets out of court, the former sharing of costs between the university and the government to do research that would benefit all Americans, that would generate health benefits for Americans, that helps support the research that turns into clinical expertise, and that helps generate jobs. All of that is going to be gutted because the government's going to renege on the decades-long commitment it's had to helping to cover the costs of doing that.
Thanks, Jack, for kind of reviewing that. And as you said, so important. Things are changing hour by hour, day by day. It's been a week since this happened. We're recording a week from this initial release. And by the time this gets out, hopefully in the next 24 hours, things may have changed. And Catherine, you brought up such an important point earlier, right? That the three missions for academic institutions: education, clinical care, and research. I think for myself as a fellowship program director, I'm thinking of like, how is this actually going to impact my fellows that are graduating in 4 months and don't know if they're going to have a job because they're waiting to see if they are going to have a early career award. Also, I'm thinking too, like, how am I going to recruit the best trainees to institutions? And I know other fellowship program directors and peer institutions are worrying about this, where we put our foundation on retaining and recruiting the best and heavily relying on our research infrastructures. But Catherine, I want to ask you just a question. Jack alluded to some of this, but would love your thoughts on what will this impact be on research and healthcare in general now in February 2025 and in the future, right? February 2026, 5 years later, 10 years later, 15 years later down the road.
Yeah, that's such a good question. And I want to say, I think it's really important that we not capitulate and take this as a done deal. I think we need to fight extremely hard as researchers, as clinicians, as humans in this country to make sure that this doesn't happen, and use our voice and use our expertise to make sure it doesn't happen and that this doesn't stand. And I do think that we have allies across the political spectrum because this will affect people across the country. That being said, if it were to go into effect, the immediate impact would be that there is not enough money from the NIH to adequately support research efforts. And there are a couple ways that people could start to deal with that. Individual researchers could try to write more of the cost of doing their research into their direct budget, for example. I think that's extremely challenging for a whole host of reasons. It assumes that the NIH would fund anything, like if Jack puts on his grant rent for his physical space to do his research or utilities costs, right? That's assuming the NIH pay any of that. It's less efficient, as has already been mentioned, because it means individual researchers are going to have to apply for funding for specific elements that could otherwise be shared. And it's highly vulnerable to the vagaries of funding decisions. So that, I think, although people talk about that as an option, I don't think it's very realistic. The next option would be for the hospital to use its operational budget to subsidize research programs and to pay its own monies toward covering these indirect costs. There is no academic medical center I'm aware of that has the budget to do that. Most budgets are extremely tight right now for a whole host of reasons. As I mentioned, the financial headwinds of providing medical care are significant and continue to mount, and I expect under the administration will only continue to worsen. And so then if you say that the institution's going to subsidize these indirects and make up the difference that the NIH is no longer providing, that's not possible for all the research programs. And certainly it would have to be focused on a much smaller subset of research programs than are currently supported at any given medical institution. So it would mean significant shrinking of the research mission at these hospitals. And additionally, that money would have to come from one of the other missions. Where I work, we run a number of community health centers that work with extremely vulnerable populations. Do we shut down community health centers to fund research into asthma? Like, how do we make that decision in a way that would ever feel good to anyone again, on any part of the political spectrum, it's really hard to imagine that's possible. And then I do think, in addition, the longer term impact, as you mentioned, is really on our pipeline of smart, motivated, curious investigators and the clinicians who work with them to solve problems. So I think we would lose trainees. I think we would lose some of our investigators to industry. Where I am in Boston, there's a lot of industry jobs available. And I think I already expect that just the threat of this will cause people to start looking at other opportunities. I think we would lose a generation of mentors from our early and mid-career faculty potentially. And I think it would really impact training in the care we provide and the people we can recruit. And then lastly, just the long-term effect on healthcare. I don't know how to I don't think this can be overstated. We would miss the opportunity to cure disease. And we're already seeing that with some of the halting in funding that's halting HIV vaccine trials across the world, the PEPFAR funding. We're seeing this in so many arenas already. We are losing a window to understand and cure disease. And that should matter to everybody. I don't care where you live or who you voted for. That should matter to everybody.
Yeah, Catherine, I was just going to add, it is so hard to explain because it becomes the pipeline becomes so long. But I was trying before this episode to just put together a list of some of these modern medical cures that have come out of this. And the list is never ending. CAR T cell therapy for cancer therapy, which is rapidly becoming one of our main treatments. Immunologic therapy for cancer therapy, hepatitis C curable treatments now. The list goes on and on for not minor tweaks to the healthcare system, to like major implications and cures for diseases. And so it's so hard to even imagine projecting yourself forward 20 years and what we could miss out on if this doesn't get sorted out.
And I think it's so important for us to really focus on the foundational role of the NIH in that. So many of our colleagues are going to say, pharma is going to take this. Pharma largely exists to take NIH developed therapies and run them through phase 2, phase 3 and marketing. Statins made a lot of money for Pfizer. Statins were funded by NIH research, right? If you think about the goal-directed medical therapy, guideline-directed medical therapy that so many of our residents love so much, right? Almost every one of those, the foundational physiologic research comes out of the NIH. No NIH, no pharma pipeline. No pharma pipeline, no pharma profits, no pharma profits, no pharma support for research. Sorry to jump in. It just
No, you're absolutely right.
heartbreaking.
And I think if you're a human on this planet who has had a medical problem or loves someone who's had a medical problem that has been treated in the last 20 years, you have benefited from NIH research. I think the other really important thing to recognize is that our funding system leads the world as a model for how to fund competitive, merit-based investigational science. And without the NIH, it's not just the NIH that's going to suffer. It is science across the world. It is discovery across the world. And therefore, it is patients across the world. And for us as pulmonary critical care doctors, you think about the drugs that have changed people's lives, like the cystic fibrosis drugs that were developed in pharma. They're all based on NIH-funded discoveries over decades of the CFTR gene, of other mechanisms in CF. That is how we got to those drugs, to Jack's point. It is not that pharma started at chromosome sequencing.
Catherine, as a CF provider myself, I was just, as Burke was giving examples, I was like, can you imagine if there were like no modulators who are now available for over 90% of people with CF? That would be crazy. That was such a life-changing development in just a span of a few years. So it's just wild to think of.
Lung cancer was a death sentence when I was training, right? It was, you didn't even need to call onc because if you saw the mass, the implications of that for morbidity and mortality were so severe. Whereas now, right, I have a 45-year-old friend who had a 4-centimeter mass discovered incidentally and is in full remission and cure, going on to take care of her children, raise her children to be productive adults, generating yet more science and more scholarship on her own. All of that's only possible because of the NIH's commitment to partnership with institutions.
Jack, and you brought this up a little bit earlier, just some of the targeted institutions that were tweeted about and having information that was released about indirect costs going forward. Well, I wanted to talk a little bit more, have you comment actually, what about those that say that this is only going to impact like the big elite coastal organizations? How is this going to impact everyone everywhere? You talked to some about this, but I love your thoughts more.
Yeah, so that's just false. That is not accurate. That is wrong. I am surprised to hear this administration suddenly talking about expropriating wealth and wealth taxes as a part of its policy. I'm surprised that nonprofit institutions are the first kind of wealth tax they're proposing. But even if you were, there's a congressional path for changing funding, and it's not memos at 6 p.m. on a Friday. But I think if you look at so many states across our union, the largest employer over and over again is a health system that is doing university-based research that's driving its growth. The other is Walmart. And for most cases, people know that there's a much better job available for them at the University of Alabama at Birmingham than there is at the local Walmart. Katie Britt, who's the senator from Alabama, wrote quite poignantly, let me see if I can pull up the quote. While the administration works to achieve this goal at NIH, a smart, targeted approach is needed in order to not hinder life-saving, groundbreaking research at high-achieving institutions like those in Alabama. And I completely agree with her. Likewise, if you go to Forbes magazine, no liberal bastion that, there's an editor pitch called What the NIH Cut to Indirect Cost Payments Could Cost Red States. And here they went through Forbes magazine, right? We know where their biases are, and estimate that Texas loses $310 million a year. Ohio, from J.D. Vance's state, loses $171 million a year. Florida loses $123 million a year. Iowa loses $36 million a year. This is just devastating to those economies and to the possibilities of mobility in that, right? I went to Michigan, so it's hard for me to say good things about Columbus, Ohio. That's just not the way I was raised. But if you think about Columbus, Ohio, right, the reason they have a giant new Intel factory there is because they've been able at the university to leverage their federal partnership in research to create great training programs that then Intel can take advantage of to build their Silicon Prairie component, right? Without the indirect costs, and these indirect costs are part of everything is tied to the same NIH indirect costs. So there's no reason to think NSF and the others won't be following suit. If this cost goes across the board, that guts OSU. You gut OSU, then when Intel's asking, do I get good employees in Ohio or do I get good employees overseas? They're much more likely to go back to answering the question, I put that factory overseas as opposed to creating economic opportunities.
Yeah.
It's bad. It's
Yeah.
just a really bad idea. It's an own goal. It's shooting ourselves in the foot. And I don't understand how a good faith effort at policy could say, American science. Yeah, that's a thing that's bad.
100%. I think having the macro view and understanding what the immediate impacts will be throughout the United States and then how that has longer term impacts is super helpful for us. I want to shift a little bit to the micro view now, too. A lot of our listeners are residents, fellows, young career faculty, people who are trainees or are pursuing grants or have early career development grants. Jack, I know you've been a very strong mentor to many trainees throughout your career. I want to know, how is this going to impact early career investigators who want to be a grant-funded researcher, who are dedicated to improving the science, but have so thus far been thinking about relying on these types of funds?
So I think there are two ways you want to think about this in the context of the broader sustained attacks on the NIH and on scientific independence, on professional peer review. So the first is, in general, folks, as part of their training, say they're going to work with a mentor. That mentor has a whole bunch of infrastructure. That infrastructure goes away. The ability to leverage that infrastructure at nights and weekends for the trainees goes away. So there's just not the same possibility. You have to buy your own centrifuge as a fellow. It's going to be a lot more nights moonlighting on Ankh before you can afford to get your research done, right? The shared infrastructures that indirects make possible also are the most palpable way in which we support great new fellows, and why fellows often come to institutions that already have some research footprint, because they know they can leverage that research footprint to do their own innovative transformational work. And we know how important fellows' brilliant insights are, and their ability to recognize emerging clinical problems are for really great insights and progress in medicine, right? They don't come from old folk like me. They often come from young transformational scientists who then I can nurture thanks to the indirects. But the second problem is also that Our trainees are looking at a list of 27 banned words and remembering 1984 and trying to understand how can dedicate my life to an American tradition of open and free conversation, of pursuing scientific questions wherever they go in order to make sure that we ask the questions that need to be answered. And in a world where it's just Orwellian, they're literally scanning grants for words. Why, as an early trainee, would you believe that's an effective way to do science? We know what happens when you start doing that kind of Soviet style science. Science dies. And so why would somebody, regardless of their interests, want to do this? And even more so, the group of our young scientists who are particularly interested in ways that scholarship can help make sure that America works for everybody and that the promise of American healthcare is delivered to everybody. That research has been particularly under attack. And so some of our most excited, enthusiastic, willing to work long hours for no pay clinicians are finding the clinician science they wanted to do being explicitly banned. And it's really hard in good faith to say, yeah, you should take a bet that although the American public has long subsidized this part of research, because they know it's good, keeps healthcare costs down, drives innovation elsewhere, don't worry, we'll come back. I don't know if we will.
Yeah, a bleak picture, unfortunately.
Sorry.
No, that's okay. It's important that we're talking about what the real impact will be. I hope that people remain dedicated and don't get totally discouraged. And I'm hoping that we can maybe give them some advice of what to do. So Catherine, and then we'll come back to you, Jack, as well. If you are someone who's wanted to be a young investigator, who's wanted to answer some of these problems, and you're worried about this, what should you be doing on a sort of granular level for yourself? And how can you prepare or protect yourself? What next steps to take?
Yeah, I think this picture is evolving so rapidly, whether it's what words are banned or what the indirect rate is. I think having really strong local institutional leadership is going to continue to be essential in providing guidance. Different institutions have approached this differently. There are reports of universities that have halted all NIH submissions while this is evolving. That is not the case at my institution. And the advice that's being provided, and which I endorse, is to continue to write your grants with budgets and plans that are consistent with what has happened in the past and to not assume that this will stand. I do think that, to Jack's point, there is an existential threat to whole swaths of research, and even to research that's not focused on one of these banned words. For example, diversity. If you are enrolling patients into a CF trial, or you're enrolling patients into an ARDS trial, even language that should ensure that you're enrolling a representative sample of patients from the communities that you serve may now torpedo your grant. Whether you should still include that language, again, I really do urge people to follow what their local guidance is, because I think different institutions have different policies on this, and I would hate to provide advice that runs contrary to what your research leadership is advocating for. I do think people should continue to write grants. I think people should continue to think about how they're going to advance medicine and advance science. I think people should continue to fight against this and use their voices to help non-medical people and people who haven't had the opportunity to think deeply about this understand what the impact will be. What the impact will be on them, what the impact will be on their local economies. My health system employs over 80,000 people. If that health system starts to collapse, that's a lot of jobs. It's not just, us high-paid elitist physicians who are going to lose our jobs. It's a lot of jobs. And that's true in every state, as Jack said. So I think using our voices to help people understand, continuing to write your science, and following local leadership guidance is probably the most and the best that we can do.
Jack, anything to add from your perspective?
So I think Catherine's right. The core thing we do is we provide best in the world care for patients that brings the science that we already know the results of to the bedside, and we preserve that for as long as we possibly can. For those who are doing science, you write great science, because the best way to demonstrate the value of science is by writing great science. That being said, it is also probably useful to do some translational activities, and different people will be able to do that for different issues about where they are personally. where their institution will support them and the like. I told my mom and said, Mom, this is what this is going to do to you. And you live in a blue state. Sorry, Mom, you live in a red state. I forget which one is which these days. She lives in a state that overwhelmingly voted for Trump. And here's some of the benefits that science has provided you, your sons, and your grandchildren. Call your senators and call your congresspersons, because in the end, this was done in one way, but if Congress institutes, this could be permanent. And it's incredibly important that everybody in every state understand how devastating a permanent institution of this would be. And then each person needs to ask, what's the right way that they stand up? My kids just moved out of the house, and so I can imagine having grandchildren. And so I've been spending a lot of time over the last couple of weeks asking, if my grandchildren ask me, what did I do in 2025? Am I going to be able to say with pride what I did, or am I going to be embarrassed? And I feel like saying science, it's good for America, is a really easy place to take a stand and to be able to act in a way that my children can tell their children that I did something that was good for them. And I find thinking about that long view perspective, right? What do you want your children to explain about your actions in this year is really useful and clarifying. As so many of us know, because we had that same thought in 2020 and we gowned up and got to work. We had that same thought in 2021 and we gowned up and got to work. And unfortunately, it's another episode where we have to gown up and get to work.
Thank you, Jack, for saying that. And we've had such a great conversation the last 45 minutes. And I feel like the four of us can stay on all day and continue to talk about this. And I think, Catherine, one thing that you alluded to earlier, which I really loved, is right, don't take this as definite. Let us work together to really change this and make positive change and impact. And Jack, I'm in my office and I'm looking at the poster that you gave me that says the team. And I think we're really at a time right now where the work that we do, the clinical care, the research, the education really transcends politics. I think we're all rooted in compassion, scientific integrity, and really support for for each other and for those that we serve. Maybe one final question for both Jack and Catherine is, what is one thing you want to leave for those listening today? How can we work together within healthcare? How can we make our voices heard moving forward?
I'm happy to take that one first. I think to Jack's point, call your senators, call your Congress people, ask your family to do the same, no matter what type of state or where you fall on the political spectrum yourself. This is fundamental to what we do and what we believe in, and it's under threat. And I don't think it's a done deal. So make your voice heard, write editorials, talk to your societies to also get their voices out there. Any option to lobby Congress to try to see reason and to prevent this from going into effect, I think is really important. And any opportunity to educate people who don't understand what the impact of this would be, I think is really meaningful. So many people are touched by the miracle of modern science. And I don't say miracle lightly. It is a miracle, the things that modern medicine has been able to cure, that if you can find a way to help people understand that's under threat, I think that's really valuable. And then I think, as you said, Christina, just taking comfort and sustenance and energy from the fact that we live here together to provide care to our patients, and that we can continue to do that even as this picture evolves.
As ever, Catherine's right. I think this is not a done deal, and we need to refuse the false hopelessness of the pseudo-intellectual. They're like, oh, everything is corrupt, and oh, what did Sartre say? That's not useful. We know how to do hard work in the face of long odds. We're all pulmonary critical care docs. Literally, the thing that our life consists of is doing hard work in the face of long odds. So refuse false hopelessness. I think the second part is I would love to see our learners organizing teach-ins. This is just the beginning of a conversation about how the modern American healthcare system works, how the rule of law works, what are the right ways for professional organizations. And I think this is a place where medical students and undergrads in particular could use time-honored approaches to make sure everybody has the skills they need. And then in general, we don't do this alone. So go back and read Letter from a Birmingham Jail one more time, and remember about how finding community and finding organizing to support community is the basis of a long American tradition of helping us be our best selves, and then go do that in whatever way is right for you. which includes, if you're a podcaster, taking the time out of really busy schedules to try to do some education about this. And I know Catherine and I are both so grateful for the two of you for the hours of work this represents around this to prioritize this when you both want to be out talking about how we should manage the latest ILDs instead, not focusing on this.
Yes, I just want to echo that. Thank you so much for having us on and for keeping this conversation going.
Yeah, thank you, guys. It's truly our pleasure. I think our mission will remain to be doing high quality education in pulmonary critical care. But I think as these things go on, it will be very likely that we have more episodes to try to help people maintain an environment where we can all pursue that mission with a focus of high quality patient care being what we want to deliver. Thank you all for tuning in and listening. Thank you, Catherine and Jack, so much for being with us. If you have any questions about this episode, definitely feel free to reach out to us. We can always do a follow-up episode and bring people back, and make sure you tune in next time. This episode was written, produced, and edited by myself and Christina Montemayor. The music's original music by Eric Rogers, and we'll see you next time.